Certainly, there are many diseases we can think of that are pandemic, and certainly one of the ones that comes to mind most recently is HIV/AIDS. What are the learnings from HIV/AIDS, both in terms of our approach to it and the way people react to it, that can be translated to avian flu?
To me, the lessons that are learned are, first of all, HIV was underestimated. It was stigmatized, and whether that would happen with flu or not, I don't know. Obviously, you can argue that there was panic there, but HIV, because of its 100% fatal nature, was initially approached as an emergency, and so what happened was people began to put in place interventions that weren't necessarily tested to start with, and I think that is something we can learn from, and they focused on the short-term issues. So the short-term issues were to try to, to treat the people who were infected, rightfully so, for fatal disease, and to use the existing preventive interventions, and not necessarily to focus on the long-term interventions. I think the challenge, in a sense, in flu has been the prominence that it's gotten. Initially, it wasn't, paid attention to at all. It got enormous prominence, which meant that national governments wanted to jump on this issue. And the question is, how was it coordinated on a global basis? And is that the role of for example, the multilateral institutions? For HIV, what we learned very rapidly was, is it the role of WHO? Is it the role of UNAIDS? Is it the role of the World Bank? Product development side, those are not the institutions that traditionally work in those areas. It's the corporate sector, it's large and small companies, it's the academic institutions. So it was different players. So we are, I think, in a transition of architecture now. I think the product development, public-private partnerships also play a role in there because they try to cut across a range of institutions across the globe. But we haven't quite found it yet. And on the global vaccine enterprise, we'll see at the end on how that ultimately plays out and is there added value. Certainly, the teams working together always adds value. But will the actual implementation be different at the end stage? We just don't know.
It's, first of all, the population at large that needs to have a grasp of the risks and the challenges and the behaviors that need to be adopted. And secondly, the first-line providers who are running these programs. The dynamics of any outbreak really depend on the interface between the health system and the public. Unless there is a real sense of engagement and sovereignty on the part of the person who is right there dealing with the first case, either in terms of reporting it or addressing it, you're going to have things spin out of control before that national level or global level is going to be able to weigh in.
We had the experience of SARS pandemic in 2003. Whole society of China learned a lot from the experience. First of all, we realized that the infectious disease is still a big problem threatening the people, not only in China, but also in the world. And also the society, the economic development should be coordinated with social development. And also, each part of the society should play a different and effective roles.
Investments in epidemiological surveillance, in upgrading response capabilities, in upgrading vaccine production, will be helpful investments whether the epidemic or the pandemic materializes or not. So I think particularly in having placed public health more centrally, away from our usual discussion of medical care, which centers around hospitals and high tech, into the really basic functioning of the public health system is the most valuable outcome of this increased awareness. And we ought to keep that momentum going and make the case for sustained investments in a well-functioning public health infrastructure, particularly the cornerstone of everything we do in health, which is good epidemiological surveillance.
A lot of that variation in the death rate, the majority actually, is explained by one simple variable, namely income per capita. So no surprise in many ways, given the patterns we see for many other health problems. But in the case of pandemic flu, the very high death rates were in poor communities. And if we take that pattern and apply it to the world today, it means that 95% or so of mortality from a replay of the 1918 virus would be in poor countries. And that brings you to some real questions about policy, because it's the same poor countries that are facing huge burdens of malaria, HIV, TB, pneumonia in children, diarrhea. And so they're faced with the threat of a pandemic and also the reality of existing problems. And I think that's why the strategies for the poorest countries may need to be looking for the win-win interventions that address existing problems but also help prepare for a potential pandemic.
It doesn't necessarily have to be a pandemic or some global outbreak for us to learn. There are many things we can actually learn from smaller outbreaks and other things that happen along the way, West Nile virus, monkeypox and other things, that we can learn about the public health response and how to improve the public health response. And one of the things that we've really emphasized is the importance of trying to institutionalize learning from these events by developing some type of formal process for evaluating the response.
At the end, all delivery is going to be local, but we also can't solve the problem completely locally. It's not either or, it's got to be both, the local response, but we have to have a global response. This whole movement of public-private partnerships for product development has been quite important because what it's allowed this group to do is bridge what normally industry would do in the normal for-profit sector and with the normal drivers, the market-based drivers, and the public sector would do in its basic research. It allows a bridging of that so one can begin to think about product development for the developing world, working with the developing world, and with companies that are focusing on innovation.
I think preparing and responding to pandemics just illustrates what one can call the sovereignty paradox. I mean, healthcare is still the responsibility of sovereign governments, which basically are sovereign to do whatever they want. And yet more and more of the determinants of health and the responses to health have a global dimension. So we really need to build the institutional base for sovereignty sharing, not giving up of sovereignty, because then we just get nowhere. But sovereignty sharing, and that requires strong multilateral institutions, like Seth just said. It requires allocating resources in a framework that takes into account the enormous inequalities of the world we live in. We need to really have a mindset of solidarity. But it also requires changing incentives